Welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to another lecture. Today we are studying the ocular anesthesia. Now the purpose of ocular anesthesia is the loss of sensation, that is called the anesthesia, loss of pain, which is called analgesia, and the third one is the loss of movement, which is called the akinesia. So these are the three important A's that we must remember with respect to the local anesthesia. Now, why are we actually giving local anesthesia? Now, we know that the eye and the ocular adnexa are basically supplied by the ophthalmic division of the trigeminal nerve, represented as the V1. So basically, by giving this regional blocks and regional anesthesia, also called the local anesthesia, we are actually making this branch of the nerve non-functional. So what is the mechanism of action of the various local anesthetic agents? The local anesthetic receptors are basically present near to the sodium channels in the cell membrane. So these over here are the sodium channels, and very close to them we will have the protein bound receptors for the local anesthetic. The local anesthetic agent is going to come from the extracellular area, pass through the cellular membrane and come into the intracellular area. Now in the intracellular area, it comes there and binds with this sodium channel like this. Now once it has bound with the sodium channel, it will not allow the sodium to pass through this sodium channels. And now we know that in the nerve conduction, basically it is what is essential is the depolarization. And what is meant by depolarization? That the sodiums will actually enter within the cell through these sodium channels inside and make the inside of the cell basically more positive. As the inside of the cells become more positive, the action potential can nicely propagate along the nerve. So what does local anesthetics do is that they will block the entry of the sodium channels, and therefore they will cause decreased depolarization, and therefore the conduction will be stopped. Now, the local anesthetics can basically be of two types. They are as esters, as you can see in this structure. The esters basically have two oxygen atoms like this, and then they can be also in the form of amides. And amides means that you will have an amide group which consists of nitrogen like this. Now, the problem with esters is that esters cause more allergies, and therefore now for the local anesthesia or the regional anesthesia, basically the amides are preferred. And the examples are the lignocaine and the bupivacaine. And in the ester group, we have the procaine as the example, which is the most commonly one used. Now, there are a lot of local anesthetics, and sometimes the examiners like to ask you what other types of local anesthetics you know of. And these are the bitoxinate, proparacaine, ermethocaine, lignocaine, bupivacaine, and ropivacaine. Now over here, I would like to give you a mnemonic to remember which one is an ester and which one is an amide. Now in the amide group, basically you will have two eyes if you actually observe. For example, in this lignocaine, you have one eye here, one eye here. So basically this is an amide type of local anesthetic. In bupivacaine also you have two eyes which are present, and therefore it is also an amide. In ropivacaine, you have again two eyes, and therefore it's an amide. And remaining everything will be a ester type of local anesthetic. So over here you can see the onset of action and the duration of action. And here are the topical, the concentration for which you should actually use. Now here the important ones are the proparacaine, the most commonly used for the topical anesthesia. The onset of action is in 30 seconds and duration is for 20 minutes. And the concentration is about 0.5%. Lignocaine again is used for both topical and also for infiltration, and the dosage is about 4%. 2%. Okay, 4% is used for the topical concentration, and for the infiltration we have about 0.5%, 1%, and even 2% lignocaine is available. Then bupivacaine is slightly longer acting compared to the lignocaine, and that's the reason bupivacaine is commonly added to the lignocaine to prolong the action of lignocaine. And you can see the duration of action is about 90 minutes, and the concentration ranges from about 0.25 to 0.75. However, the commonly used one is 0.50%. Then we have the ropivacaine. Now ropivacaine has a very long duration of action, almost about 6 hours, and the percentage is 1%. The problem with ropivacaine and the longer acting agents is that it needs prolonged padding of or prolonged patching of the eye post operatively, because the anesthetics will take time to wane, and therefore the patient might report diplopia post surgery for quite a long period of time. Now, coming to the topical anesthesia, topical anesthesia is nothing but we're using certain drops directly and injecting them into the eye of the patient, and this is basically done for superficial corneal and conjunctival procedures like removal of foreign bodies, removal of concretions, suture removals, okay, and sometimes even in phaco emulsification these days is also being done under topical anesthesia. Okay, now but the thing is that we need a lot of cooperation from the patient to do a phacoemulsification under topical anesthesia. And also, prior to regional blocks, sometimes like the subtenons block, we will actually instill 1 drop of local anesthetic into the onto the conjunctiva of the patient or into the fornix of the patient, okay, before giving the retro or the peribulbar block. Now, the commonly used topical anesthetics are the lignocaine. Here, the concentration of lignocaine when it is used as a topical anesthetic is very important. It's about 4%. And then we have the paracaine. The concentration is 0.5%. Bitoxinate is about 0.4%. And then we have cocaine, again 4%. Cocaine is not so famously used. And then we have the other kinds of topical anesthetic agents also called the oxybuprocaine, which is also called the binoxinate. Now, the special feature about this binoxinate is that it comes in combination with the fluorescent sodium, and therefore you can use this topical anesthetic agent directly for the applanation tonometry, because you need not install the you do not instill the paracaine separately and fluorescent strip separately. You can use these drops, which is like a combo coming up with the local anesthetic along with the fluorescent agent. So what are the benefits of giving a local anesthesia to the patient? The benefit is that the analgesia also lasts in the post-operative period, and the respiratory and cardiovascular stability is maintained, unlike the general anesthesia where you actually put an endotracheal tube or a laryngeal mask where you need to maintain the airway. That is not required in local anesthesia. The muscle relaxation, that means the akinesia, is very good, and there is no interference with the airway since we are not meddling with it. The metabolic and neuroendocrine stress response that occurs to the general anesthetic agents that we use is not there in local anesthesia. So we are basically doing everything locally. Systemic agents are not used, and therefore all your cardiovascular, respiratory, and even the excretory systems are all normal, and they are going to be stable. Moreover, it's most cost effective. The anesthesia, especially the general anesthesia, is really costly in terms of drugs which are used, the equipments which are used, and also the manpower. Now, also it is very less intensive. It needs very less intensive post-operative care. Specifically for the daycare surgeries you can discharge the patient as well. The pad can be removed the next day, and the patient need not be on NBM, that is the nil by mouth. The patient can actually eat immediately after surgery as well. It allows easy early discharge and ambulation. However, there are certain places where it is not advisable, specifically in kids who might not cooperate for the surgery, especially age below 15 years, and bleeding disorders, because in bleeding disorders, when you actually put a needle, which I'm going to tell you about in a while, about the peribulbar and retrobulbar block where we're using a syringe, what might happen is that we might actually touch a blood vessel, and that might cause a retrobulbar hemorrhage. So all those bleeding disorders, patients who are prone to bleed for longer period of times, those patients, it's better that they undergo surgical procedure under the general anesthesia. Then if the patient has an allergy to local anesthetic agents, whether it is paracaine or is it lignocaine, they should also undergo the general anesthesia. Patients who have psychotic tendency, uncooperative patients, should also undergo general anesthesia. If the patient himself does not want to be awake during his surgery, and if he chooses general anesthesia over local anesthesia, the patient should be taken for surgery under the general anesthesia. Then there will be some patients who will have chronic spontaneous cough orthopnea, shortness of breath while lying flat on the stretcher or on the bed. So those patients also should not be advised local anesthesia, because the cataract surgery is usually done with the patient in a supine position and with a blanket for most of the time on his face and covering his mouth and nose. So if a patient is actually suffering with shortness of breath, it's going to be very difficult for the treating surgeon and also for the patient himself to do and complete the surgery. Similarly, patients who have Parkinsonism and they have some sort of head tremors, it's better they undergo the surgery under general anesthesia. Alzheimer's disease, claustrophobic patients, again because of the blanket coming over to the head, it's advisable that they undergo the surgery under the general anesthesia instead of going for the local anesthesia. Coming to the regional blocks proper, the regional blocks are divided into two types: the nerve blocks and the local infiltrations. So here in this video, we'll particularly be discussing few of the nerve blocks. So nerve blocks are various types. They are the peribulbar block, retrobulbar block, parabulbar, also called the subtenons block, the intracameral anesthesia, facial block, frontal block. Now here in this video, I will basically be talking about the peribulbar block, which is the most commonly given now, retrobulbar block, parabulbar, and the subtenons block, and the remaining three will be covered in the next video. Now the regional blocks of the eye, basically we have the retrobulbar. Now if you will remember from the surgical spaces of the orbit, the retrobulbar cone or the intraconal area is nothing but it's a cone which is formed by the four intraocular muscle, right? So these intraocular muscles are going to form a conical shape space behind the eyeball, which is called the cone of the eye. And when the anesthetic agent is directly instilled inside this conical area around the optic nerve, which actually have most of the nerves present in it except the fourth cranial nerve, which is present outside the muscle cone. Okay, and when we inject the anesthetic directly into this area, it is called the retrobulbar block or the intraconal block. However, when the anesthetic agent is actually instilled outside this conical area without piercing this cone, without piercing any of the muscles or the intramuscular septum, then that is called the extraconal. As the name suggests, it is outside the cone, and it is referred to the placement of the needle outside the muscle cone. Much safer compared to the retrobulbar. Then we have the subtenons block, which refers to injection of the local anesthetic agent beneath the Tenons capsule. So we know that the eyeball has sclera. The sclera has an episclera on top, and on top of that we have the Tenons capsule, and on top of that we have the conjunctiva. Now below the Tenons capsule is the subtenon space. It's a potential space where we can actually inject the anesthetic agent, and that is going to diffuse all throughout the globe, and slowly through diffusion it is going to cause the anesthesia. Now it is quite safer compared to the retro and peribulbar block, and I will tell you in a while why. And the subtenons block is also referred to as the parabulbar block, pinpoint anesthesia, or the medial episcleral block. Then we have the intracameral anesthesia, which means that you are injecting the local anesthesia directly into the anterior chamber. Now let's talk about the individual blocks. First, let us talk about the peribulbar injection or the peribulbar block. Now, the peribulbar block, as the name suggests, is basically putting the anesthetic agent outside the muscular cone of the eyeball. Okay, now it is basically done using a 25 gauge needle with a 2.5 centimeters length of the needle, which is about 1 inch, and the needle is basically disposable. You're not going to use the needle for the other patient. So here the length of the needle is very important because you are not going to pierce this muscular cone. Okay, so these are the four muscles which are going to be present: the superior rectus, the inferior rectus, the medial rectus, and the lateral rectus. So in between them we have the retroconal area or the intraconal space. Now we are going to inject the anesthetic just outside this cone, and that is called the peribulbar injection. Here the needle is smaller needle, which is about 1 inch, and 1 inch is about 2.5 centimeters, and the gauge of the needle is also 25 G, which is a thinner gauge needle, thinner bore needle. The patient will be lying supine, and the patient is going to be asked to look straight up. Okay, so give a fixation target and tell the patient to keep looking straight ahead. The patient should not move the eyeball during the procedure, and he should not close the eyeball or blink the eyeball as well. Now, and the thing is that we can give it either directly through the skin, which is called the transcutaneous injection, or you can retract the lower eyelid and give it through the conjunctiva, which is called the transconjunctival way of giving the peribulbar injection. Now over here I will tell you with the diagram as well what are the various sites where you give the peribulbar injection. Now the first injection, and for most of the cases this actually suffices, is the lower site for giving the peribulbar injection, which is the dividing the lower lid into 3 parts and giving the injection at the junction of the medial 2/3 and the lateral 1/3 of the lower eyelid, okay, adjacent and parallel to the orbital floor for about 2.5 centimeters. So if this is the eyeball and this is the lower lid, what you're going to do is that you're going to divide it into 3 parts. Okay, in your mind you have to divide it into 3 parts. So the medial 2/3, 2 parts, and this is the lateral 1 part. At the junction of the medial 2/3 and the lateral 1/3, this is the site of entry for the peribulbar injection. And now you're going to enter straight perpendicular to the plane of the patient's face, and we can also call it as parallel to the direction of the orbital floor, and you inject your needle entirely in the same direction, and that is the reason it is written 2.5 centimeters, because the length of your needle is 1 inch and you're going straight inside that entry point, okay, perpendicular to the face of the patient, and it is parallel to the orbital floor. Okay, in this case, since you're not entering it the muscle cone, you don't have to change the direction of the needle. The needle will go straight perpendicular inside. Okay, next, so in most of the cases the block will actually come right with this injection. However, you can give additional blocks also. The sites are, number 1 is the medial to the medial canthus. Over here the medial canthus is located, so just give it medially to the medial canthus. In the same way, go perpendicularly inside to a depth of about 2.5 centimeters, which is nothing but the complete needle has to go inside, and give a 3 ml of anesthetic mixture again. And then one more location is in the inferior medial to the supraorbital notch. Supraorbital notch is located somewhere here in the medial 1/3 and lateral 2/3. So in the lower lid you had the medial 2/3 and lateral 1/3, and in the upper lid you have the medial 1/3 and the lateral 2/3, and in between them you will have a supraorbital notch. So you go inside inferior to the supraorbital notch and you will deliver your local anesthetic. However, this is the most risky position to give the block, and also called the superior position for giving the peribulbar block. So if possible, try to give it perfectly in the inferior lid, and then if you have to repeat, you can give medially, and the third most preferred site is the superior block, and following that you have to do an ocular massage. Now this picture over here gives you a rough estimate of an inch. So if you take your thumb, the distal phalanx, that is the tip of the thumb, and the distal crease of the thumb, and if you actually measure the distance between them, is approximately 1 inch. So that is the size of your peribulbar needle, and 1 inch is about, as you can see here, is about 2.5 centimeters. So the sites of peribulbar injection, as I told you, inferiorly it is the medial 2/3 of the lids and the lateral 1/3, and the junction between them is where you're going to give your injection. The second site is medial to the medial canthus. So this is the medial canthus, this is the caruncle over here, so medial to that you will give. And the third site is in the supratrochlear notch, that is in the medial 1/3 and the lateral 2/3 of the upper lid. So this picture over here I've taken to show you how the orbital floor is present. So it's slightly directed like this. So you have to enter somewhere here, that is the lateral 1/3 and medial 2/3, and put your needle straight inside and make sure that there's no resistance. That means you're not touching basically the eyeball. Now superiorly it will be somewhere here. There'll be this here is a supratrochlear notch, so within that area, and medially you are giving near the inner canthus. So here will be your medial check ligament. Sometimes you will feel some sort of resistance while going inside. You will have a feel, and that is because of the puncturing of the medial check ligament, which is normal. So now some of my thoughts on ocular massage. Now some people say that after giving the block you have to give a firm pressure. Now the idea of giving a firm pressure with this kind of instrument, which is called super pinky or pinky, is basically to cause easy diffusion of the local anesthetic around the globe. So you have injected it here, and with your massage, what will happen is that with the compressions, the local anesthetic will get diffused around the muscle cone and will cause the anesthesia. Now, some people say that firm pressure to the globe with a gauze piece can be applied. Okay, and it should be enough that it causes occlusion of the central retinal artery, so that any possible retrobulbar hemorrhage will actually have a tamponade, and they advise it for about 3 minutes, 90 to 120 seconds. However, alternating, some people say that we should give alternating seconds of firm pressure, that means about 10 to 15 seconds pressure and 10 to 15 seconds release of that pressure, so that you allow the perfusion of the central retinal artery. However, studies by Sohan Singh Harry have actually shown that the retina can actually tolerate up to 90 minutes of non-perfusion before permanent damage is actually encountered in the retina. However, what I prefer is that alternating 10 to 15 seconds of firm pressure with 15 seconds of release, and this works quite well for the patients. And the first sign of getting a block is the development of ptosis, and then you get gradually the kinesia. So what are the indications of peribulbar block? Peribulbar block is basically done for cataract surgeries, for glaucoma surgeries, keratoplasty, vitreoretinal surgeries, and even the strabismus surgeries. So it's quite a safe type of block, and now it has actually superseded the retrobulbar block, which was associated with a lot of complications. So now we'll be discussing the little bit dangerous type of block, which is the retrobulbar block. The retrobulbar block, as you can see, the gauge of the needle is 22 gauge needle, which is actually a much thicker bore compared to the one that we are using for the peribulbar block. The length of the needle is also 3.5 centimeters, which comes to about 1.5 inch long. So it is definitely longer than the one which we are using in the peribulbar. And the reason is because you have to actually perforate this muscle or the intramuscular septum and enter the intraconal area near the optic nerve and deposit your local anesthetic in this position. So the site of entry for the retrobulbar block will also be the same, the junction of the middle and the lateral third of the lower orbital margin. But the thing is that initially you are going to enter like this, and as you enter, after some time, say you are going to enter it like this backwards for some time, okay, and then that is about, say, some people say it is about 1.5 centimeters of your needle you have to enter, and after you have entered 1.5 centimeters, then you are going to turn the direction of the needle, as it can be seen over here, upwards and medially towards the apex of the orbit, so that now you will enter this orbital cone and orbital intraconal area. So it is about 45 degrees medially and 45 degrees upwards. Okay, so the direction of the needle will change. So as the needle will pierce this intramuscular septum, you are going to feel a resistance or giving up of the resistance. And after you enter, before injecting, always you have to aspirate 1 to 2 ml to see if there's any blood which is coming out from your needle. Okay, if there's any blood which is coming into your syringe, that means you are inside some vessel. Then you have to immediately withdraw your needle back and not inject the local anesthetic agent. Okay, however, if there's nothing like that, then you can proceed with injecting, and the amount of retrobulbar block for the anesthetic that you give for retrobulbar block is about 3 to 4 ml only. Now this picture is telling you in detail. So first you enter like this outside the cone. Once you have entered about 1.5 say centimeters, then change the direction and go upwards and medially. Okay, so you entered like this at the lateral 2/3, lateral 1/3 and medial 2/3, like this you enter. Now once you realize that okay, 1.5 centimeter of the needle has been introduced, now you change your direction into upwards and medially and enter the intraconal area like this. Now the third type of block under the regional blocks is the subtenons block. Now for giving the subtenons block, again you need to have topical anesthesia in place and the eye speculum in place. Now the patient is asked to look upwards and outwards so that the inferior nasal quadrant is nicely exposed. The reason for exposing the inferior nasal quadrant is because you are going to actually give a nick in this area, you holding it using a non-tooth forceps, and then you're going to cut it with a blunt tip scissors, and these scissors are basically the Westcott scissors. So you're going to use the scissors, make a nick, make a hole through this, and it is through this opening into the conjunctiva and into the tenons you're going to enter the subtenon space. And in order to reach the subtenon space, you're going to use a blunt plastic cannula. Now, what I want you to notice over here is the word blunt. So you're not using any needles that we used in the peribulbar and the retrobulbar block, and that is the reason why the subtenon block is very safe with very low risk of perforation of the globe. Now you're going to introduce this cannula up to the posterior part of the eyeball, and you have to actually go past the equator of the eyeball and inject the local anesthetic deep to the Tenons fascia. So this is a first picture which is depicting you about the subtenon space. So Tenon space is present below the Tenons capsule. You can see this bent cannula, it will be like this. So this cannula you have to insert like this. Because of that bend which is present, it will actually slowly progress and gradually it will progress beyond the equator and go to the posterior pole, and this is the point where you're going to actually inject your local anesthetic agent. So the advantages are that it is painless for the patient, it's quite safe and it's reliable, and there is no sharp needle, so all the serious complications can be avoided.